All right, good morning, everyone. My name is, welcome to the session. This session is titled Advancing Indigenous Cultural Safety Through Humility and Renal Care. You're at the right session? Okay. My name is Helen Chu, and I'm a Chinese settler on the Coast Salish territory since when I was in grade 9. So now I'm a quality lead at the BC Renal Agency, and I am moderating this session today. First off, I'd like to acknowledge that we're gathering on the traditional unceded territory of the Coast Salish people as home of the Musqueam, Squamish, and Tsleil-Waututh people. And our learning objective for this session is about understanding the unique challenges and the importance to overcome disparity faced by our Indigenous peoples and families in renal and transplant care. So we're not going to make you feel too comfortable here because this is quite a challenging topic to talk about. And secondly, we hope that we'll learn together on how Indigenous cultural safety training can enable all of us here to embrace culturally safe practice in what we're doing through humility. And so it is my great honor and privilege to introduce our two speakers today. One is Tiffany Bell, coming all the way here from Haida Gwaii, and she will be sharing her experience with us, her kidney journey with all of us here. Danielle Mitchell from PHSA, Provincial Health Services Authority, Indigenous Health, and she will be presenting on the topic with the work from her group. But I'll let the two of them to introduce further about themselves in their own words. And we want to ensure you that this presentation will be very interactive. There will be opportunity for questions, and towards the end of after both of them present, if you could hold off your questions until then. And if you are worried that you won't remember, you can always put it down on the app in the question sessions. And feel free to tweet, but we ask that on the slide, when the quote come up, you don't take a picture of those slides or tweet those because there are privacy issue around those. Okay, so without further ado, Tiffany, you ready? Sure. Thanks.
Hadlastas, tu dagvias hinudi kiagan, tijath, janas iskagan, dalangath kalagan. Good people, my name is Small and Tough. I am from the Joth clan, and I'm happy to speak with you. My English name is Tiffany Bell. I am a member of the Haida Nation. Being from the Joth clan, I reside on the unceded territory of Haida Gwaii. It allows me to practice my culture and harvest my traditional foods. I have been an information and communication technology trainer for Indigenous Northern Affairs Canada and Aboriginal business counselor for Haida Gwaii Community Futures. I was trying to hide.
You can stand over here.
Okay. An Aboriginal counselor for Haida Gwaii Community Futures, business development officer, special projects coordinator for the Aboriginal Business and Community Development Center in Prince George. I've been a mentor for the Forum of Women Entrepreneurs, and I've been trained through Women's Enterprise Center as a peer mentor facilitator. Currently, I'm the project coordinator for Indigenous Business Development Services program that Haida Gwaii Community Futures has taken on. I myself have chronic kidney disease, and at the current time, I'm in stage 4. At the age of 27, I was in college, and I had a headache. And this headache wouldn't go away. I would wake up with this headache and go to sleep with the same headache. The doctor I was seeing at the time told me to take 3 Tylenol and ibuprofen every 4 hours. I looked at him and I said, that's a lot of medication to be taking all the time. Can't you just find out what's wrong? And this doctor looked at me and he said, actually, I think the headaches are just in your head. During that time, I was young and I got quite hostile with that doctor, and I got up and I walked out. I walked up to the street to another doctor and I told her about my headaches, and she started multiple tests on me. They sucked vials of blood out of me. They put me under MRI machines, different ultrasounds, and she said I was diagnosed with high blood pressure. One of the tests that they did found out I had a cyst on my left kidney. During that time, I was living in Prince Rupert, and upon completion of my business admin diploma and entrepreneurial tourism management certificate, I returned home to Haida Gwaii. The doctors watched the cyst, and they had me fly to Prince Rupert and have it scanned every 6 months. Every time I returned to the doctor for the results, they would tell me the same thing. Yes, the cyst is getting bigger. They never said they would remove it or test it or do anything with it, and I'm not sure why, but all of a sudden they stopped. They didn't want to check it anymore. They didn't want to see what it was. I'm not sure if it was just because I was a First Nations person, I didn't matter. And this is where I should probably let you know that I live on a First Nations reserve on Haida Gwaii, and we still have clinics with no consistent doctors. We have student doctors that come, and they come and they stay for maybe 3 to 6 months and they leave. In 2013, my headaches returned with a vengeance. I was again put through weeks of testing, some of the tests lasting 7 hours. It became a pattern of getting tests done and returning to a doctor's office and hearing, no, these tests came back fine. These tests had gone on for a year. This time I was living in Terrace with a regular doctor. I was sent to Prince George for a couple of tests, and this time I had an appointment at 8 a.m. I showed up at the hospital a few minutes earlier. I met with an older couple in the same room. We sat down in the room and a nurse walked in to start an orientation for patients with chronic kidney disease. I was shocked. I stopped her and I started asking, am I supposed to be in this room? And she read my name. And all this time, all these testings, all these doctors, I never even heard of chronic kidney disease, and my doctor had not said anything about this or about me possibly having chronic kidney disease. When I left the hospital, I remember being in a daze. I looked up and I saw the clouds spinning. My whole life had changed. I was angry at the doctor for not telling me about the diagnosis. I was not accepting that I was a chronic kidney disease patient. I continued to eat the same foods that would cause the headaches, the pains in my stomach and the back. And one day I finally accepted it and I wanted to fight it. The only way to fight CKD is to learn as much as you can about the foods, portion control, exercise, and medications. I was now a patient with the renal clinic at the Prince George Hospital. Once you are a patient, you get your own nurse, dietitian, nephrologist, pharmacist, and social worker. I have my blood work done on a regular basis, and if anything comes up with my blood work, the nurse will phone me. I call the dietitian or email her with any of my concerns about my cultural foods. Shelley will look it up and she'll find any information she can and tell me about any of the concerns. I also have cultural healers that suggest things for my kidneys, like juniper berries. I'll then call my pharmacist and ask if it's okay to try before I take anything. She'll find any information she can on it and tell me if it's okay or not. In my culture, we have healers that will make teas and tonics with natural medicines that I myself have not been able to identify to the dietitian or pharmacist. It is unknown if these natural medicines will help or harm my kidneys. Some of these medicines have been suggested for me from the elders in the community. However, I chose not to try it. During my last appointment at the kidney clinic, I was already done my appointment. We sat down in the waiting room as the nurse was going to get my paperwork ready. And then the doctor came back to me, the nephrologist, and he asked if I would go and talk to him again. My sister and I went back and sat down with him. He then said I would be eligible for a biopsy on my kidney. This biopsy, he said, might be able to find out what causes the kidney damage, but usually it is something that cannot be repaired. I asked about recovery time and time off work, and he asked if I would try it. I said no. I don't want to bother taking the time off work for something that probably won't help anyway. It kind of annoyed me, and it seemed as though the test was an afterthought, like I was just going to be another guinea pig for one of their tests. As I live on Haida Gwaii, this kind of appointment takes me 2 flights. One flight I have to get from Haida Gwaii to Vancouver. They make me take my bag off of the plane, go through security, and run to the next plane to get to Prince George. If I have to travel by ferry, as many of our Indigenous people have to travel through the cheapest way possible, it would have me drive 2 hours to get to the ferry, then an 8-hour ferry ride, and another 7.5-hour drive just to get to Prince George. During winter months, the roads aren't good, and you can't depend on the weather for the ferry. A 2-hour appointment out of town can cost me a week without any work. Most of my appointments now are through telehealth. Northern Haida Gwaii Hospital and Health Center is where my telehealth appointments are set up. Once I arrive, a staff member will bring me to an empty room and turn on a TV. The appointments are a lot faster, but they aren't as thorough as when you see them in person. I'm happy that I get to remain in contact with the renal clinic without having to take so much time off work. But you don't get as much information as when you see them in person. Another huge thing to point out is that there is no dialysis center on Haida Gwaii. If you're not eligible for home dialysis, you have to relocate. This means leaving your family, your cultural events, and harvesting your own food in order to get dialysis. Potlatches in my village consist of feasting on traditional foods, shellfish, fish, deer, fried bread, and berries. A lot of my traditional foods are not on the food listing for chronic kidney disease. I tend to phone my dietitian and bring these things up. and she'll tell me how much I can or if I can eat any of these. Some of the foods she'll have to further investigate before she gives me an answer. Once I started to research about CKD, I came upon some information that was alarming to me. I noticed that Indigenous people have a higher risk of being diagnosed with chronic kidney disease due to diabetes and obesity. Indigenous people are also more likely to die on a waiting list than to receive a kidney transplant. This encouraged me to contact BC Transplant and volunteer. I started to set up tables through Aboriginal health fairs, friendship centers, and other such events throughout Prince George and collect organ donor registrations. My hope in doing this was that one day, one of these registrations may help myself or any other First Nations member in need of an organ, and to raise awareness about chronic kidney disease and Indigenous people. As of September of this year, I was working 3 jobs. I told one job that I can only work casual now because my health is not so good. By the end of September, I was terminated from a second job as my performance was lacking. Currently, I work full-time as a project coordinator for Indigenous Business Development Services. I have times right now working one job seems like too much. One of the things that they mentioned was I'm just another Aboriginal that's lazy and cannot work. I fight hard for my jobs, for my Indigenous people, and I will continue my fight with chronic kidney disease. Thank you for listening. Hawa.
Danielle is making her way to the podium. I really want to thank you, Tiffany, for your courage and your opening to share, being so open to share both the good and bad of your experience with us. That's very important. Sometimes we don't see that through your lens, and that's really important for us to know about, and it's also set the context for what Danielle is going to talk about.
Thanks. Tanse, everyone. Can you hear me okay in the back? Okay. Okay, thank you. Danielle Mitchell and Nasiga's son, Nia Nehio Ekwa Métis, Nia Nitsanuk, Muskeg Lake Cree Nation, and Michelle First Nation in Alberta. So I introduced myself as Danielle Mitchell. I said hello, and I'm a Cree and Métis. My family comes from the Michelle First Nation in Alberta and Muskeg Lake Cree Nation in Saskatchewan. I live and work on Coast Salish territory here, and I'm very happy to be here with you all. So I'd like to begin just by acknowledging Tiffany's story, and this is what brings me here. Stories like Tiffany's, stories like that are happening to Indigenous people all over the province, all over the country. My uncle is actually someone who may die waiting for a kidney transplant as well. So this is very personal to me, and I know this work is personal to many Indigenous people, and I hope it's also personal to non-Indigenous people. So today I'll provide some context and background to the issue of anti-Indigenous racism and what underlies that in the healthcare system. We'll provide some examples in renal care and in other areas of practice, and I'll also spend some time talking about how racism shows up for Indigenous people specifically. At the end, we'll share some insights about some of the work we've been doing within the Provincial Health Services Authority around organizational change and anti-racism at an organizational level, and then as well, of course, at the interpersonal level. So it's probably not news to you that Indigenous people experience racism in all facets of life, of social life. Compared to every other population in Canada, Indigenous people experience the greatest inequities, and yet we also experience the greatest barriers to access and care, and Tiffany shared a little bit about that. When it comes to Indigenous people, racial profiling and discrimination is also like no other group in Canada. And this has a profound effect and impact on our health. For example, Tiffany again shared some of those disparities that you may be familiar with, Indigenous people being 2 to 4 times higher risk for kidney failure than non-Indigenous people. And we're also less likely than non-Indigenous patients to visit a kidney doctor and to receive a kidney transplantations. So some of you may be familiar with Brian Sinclair. He's an Indigenous man who died from a fully treatable bladder infection in an ER in Winnipeg after waiting 34 hours to be seen. So even though this happened in Winnipeg, this is not unique to Winnipeg. This happens everywhere across Canada, happening right here in Vancouver as well. And we often don't hear about these because incidents like this are not reported. We hear about tons of examples of discriminatory treatment through our work in the SANIUS program, which I'll share with you here. So some of you may have also heard about the Indigenous Cultural Safety training that our program offers. So I've been involved with the SANIUS program for about 3 years now. Since its launch in 2009, 60,000 people have been trained across Canada. So it started in British Columbia with a focus on health and mental health, expanded to Manitoba as well as to Ontario, and people are accessing the training across Canada. We also have training for child welfare, for justice, a variety of social sectors as well. And the program is unique because it's online and facilitated. It's also theoretically grounded in critical anti-racism and transformational learning principles and theory. So it's about really helping people understand how to move through a journey of deconstructing narratives, deconstructing stereotypes, and addressing racism. It's also primarily intended for non-Indigenous people. This comes from the place that we know that non-Indigenous people are necessary to addressing racism. We need to see a change in behaviors and a change in attitudes. So before we can have a conversation about what we can do to address anti-Indigenous racism, we have to start talking about the realities of what Indigenous people experience. In this presentation, I'll be sharing some examples of harmful care that Indigenous people often receive in the health system. These examples are taken directly from our SANIUS training and used with permission for the purposes of training. So like Helen mentioned before, if you're going to take any photos, just please respect that privacy when there's quotes up. I also want to note that Indigenous people, I want to note that sometimes people in general will react to these examples. This is normal, it's okay. Particularly for Indigenous people, it can be difficult to hear. These are, because it's personal. It's our families, it's our communities, it's our people. So I just want to offer that and pause for a second just to give people a little bit of a moment to adjust. So I'm wondering if anyone can read out this quote for me that's non-Indigenous. Just anybody yell it out. You look like you're smiling in the front. Maybe you can help me out.
When I asked the physician why he insisted on the rectal exam when it was likely that this method suffered abuse in a residential school, the physician stated that he had set the ground rules for assessment and treatment, or they will just try to get away with drug seeking, and that the abuse in residential schools was over-reported.
Thank you. Thank you. So what do people think about this? Yeah, pretty heavy, terrible, yeah. And I want you guys to think about what was going on for the physician who made the comments. How do you think his attitudes impacted the care of this elder? And we're going to take a closer look at some examples later on and help deconstruct that. So how did we get here? On the left-hand side, we have an image that many people in Canada are familiar with, so a model of liberal ideals, of democracy, of tolerance, multiculturalism. Juxtaposed to the right here is the reality of Canada that's experienced by Indigenous people and other racialized Canadians, of course. And that has been shaped by racist ideology, paternalism, cultural genocide, violence, and of course, racism. And what's interesting in both of these images is that they're both from the same province. It happens to be Manitoba. But you would find these perspectives consistent across Canada. And the issue is not that one is right or one is wrong. The issue is that each reflects a standpoint that is shaped by race and colonial context, which we'll get into a little bit. And the fact that most of us are more familiar with the rhetoric on the left and not familiar with the reality on the right speaks volumes about what's at the heart of racism. And racism in Canada and racism in all human service sectors, including healthcare. So what is racism? As you can see, colonialism is at the root of racism for Indigenous people in Canada. This is an illustration by Dr. Charlotte Lope, and she shows how racism is a determinant of Indigenous people's health. And we'll be talking quite a bit about racism in the presentation, so it's important, we kind of provide context here and you understand what I mean. So Dr. Yin Paradies notes that racism is a form of oppression that falls under the rubric of racialization, a system where people are divided into races with unequal power between them. And we highlight that because at its core, racism is about believing one race is superior to another. And it's embodied in the attitudes, behaviors, and practices which increase or sustain these differences in power. So I know it's heavy, it's a lot, but it helps provide some context of what we're going to move into. So we can't start responding to racism until we have a better idea of what it is, how it shows up, and where it manifests. Racism is alive, it changes, it's evolving, and it takes on many different forms. So the iceberg is a model that we use quite often to help illustrate how racism occurs at different levels. So we have the interpersonal level, top of the iceberg. Usually this is manifested between individuals. It can play out in one person making a racist comment towards another person. At a structural institutional level, we're really talking about organizational policies, practices, and workplace culture, so that upholds and enable racism to occur within organizations. How this can show up: all leaders of an organization are from the dominant racial group. So all senior leaders are white. At a systemic level, we're talking about the societal norms, media, public discourses that shape our understandings of racism. And Indigenous people are overrepresented in some of the poorest neighborhoods. So that's an example of systemic racism. Other comments, that we can help to demonstrate this at an interpersonal level: they don't belong here, for example, or don't worry about him, he's probably drunk. At the structural institutional level, we often hear they are not qualified to work here, or don't they have a special program to deal with those people and their problems. At a systemic level, if they just worked hard enough, they wouldn't be living in poverty, or they just need to get over the past. So these are common, we hear these very often. So we've learned many things about how racism shows up in the healthcare through our years of work in the SANIAS program, and as well as addressing racism at the organizational level. And one of the things we've learned is that racism in the health system is different for Indigenous people than any other group. We've also done our own research using our data from SANIAS, which has shown that when it comes to Indigenous people, there are common stereotypes that inform the way we receive care. So the wordle behind me illustrates some of the most common stereotypes that we've seen in our data. The bigger the word, of course, the more common the stereotype. So I'll just give you a sec to read that. And so we recently had some of our data analyzed by a doctoral student who looked at thousands of examples of harm resulting from stereotypes. So these examples are described and provided by participants who take the training, so providers actually, mainly. You can see that the top 10 stereotypes from this analysis are alcoholic, as we saw in the previous wordle, drug addict, that we get or want free stuff, we're promiscuous, we're not smart, we abuse the system, we don't cooperate, we're lazy, we can't get over the past, and we're bad parents. And so, of course, you can see how that would show up in an ER context, for example, with social work. These findings are also consistent with our earlier data dives that we have done, and as well consistent in actually the literature as well. And so when we look at, or take a closer look at the data on stereotyping, we saw some common behaviors that occur. So reflecting back on some of the examples that we've talked about in Tiffany's story, think about some assumptions that have informed practice behaviors. Sometimes this behavior shows up as one, or at times it can show up as all that Indigenous people experience. So some of these practice behaviors, less effort goes into our appointments, there's misdiagnosis, improper procedure, no treatment, no medication is provided, our conditions are minimalized, delay or denial of service, or pain medication is withheld. Wondering if anybody else would like to take a chance at reading a quote for me? Non-Indigenous person? Yes, please.
I'm an oncologist. I have many Aboriginal cancer patients who have palliative care cancer diagnosis.
So this is what anti-Indigenous stereotyping looks like in action. So this is not an uncommon situation. There are many examples where Indigenous people have not been provided the pain medication that they need. They've received misinformation about their conditions, and the stereotypes about alcoholism and drug-seeking behavior are demonstrated in this example. And as you can see, this is also an example where several other stereotypes and beliefs are being activated, which we'll dive into. So this is a model that we use that is we found helpful for deconstructing these examples or these experiences that people have, and trying to understand how stereotypes become activated and then turned into discriminatory behavior. And as you can see, the underlying colonial ideologies in society certainly inform and shape the beliefs about Indigenous people. These beliefs and stereotypes inform our attitudes or prejudice, which then affects our behavior and how we treat Indigenous people in care. So by becoming conscious of stereotypes that we hold, we can shift our attitudes and prevent this discriminatory behavior. And this is how we interrupt the pathway to harm. So we'll unpack some examples together as we move through. And I want you to think about what drives the attitudes and the assumptions and what drives the behavior. Someone else or same people? Thanks, yeah.
One of the most recent examples is a young woman being discharged from ER twice and was assumed to be intoxicated when she really had a head injury. She ended up in EMS care after a seizure and was taken to the hospital where she died shortly thereafter.
Thanks. So here's an example of how stereotyping can affect Indigenous people, and in this particular case, this Indigenous woman. So anyone want to take a chance at what is the stereotype that's showing up in this example? Yeah, exactly, alcoholism, that we're all drunks. So what was the discriminatory behavior? Where does that show up here? I think I heard discharged from the ER, exactly. And then what was the impact of this on this Indigenous patient? Death, absolutely. So we can see this example helps us demonstrate how stereotypes are activated. One more, somebody else.
In the UR, Indigenous women was having joint surgery. Surgeon was being brutal and tampering with the patient that would no doubt result in increased pain and a longer recovery time for the patient. The comment he made was, "I don't know why I'm having to do this surgery. She won't get off her lazy arse off the couch anyhow." I happen to know that the patient was an ex-member of the police.
Yeah, it's okay, excellent. Yeah.
I remember being horrified, but frightened to identify his treatment of the patient as abusive, for fear he would continue his tirade and the patient would suffer more. It was a helpless feeling.
Thank you. So another example of stereotyping in this context in the OR. So what is the stereotype? And we have it laid out here, that the person is lazy, right? And I also, often I encourage people to think about too, what does it matter that this person is a member of the police? It doesn't matter what the profession is, right? So this person has emphasized that, but it does not matter what career or what people are involved in. So what is the impact of the behavior? Of course, increased pain and longer recovery time for the patient. And also we ask, what is the accountability for this behavior? So what contributes to the activation of stereotypes? Here are some conditions that have been shown to contribute to stereotype activation. So conditions where there's high anxiety, high stress, decisions have to be made quickly, there's urgent nature to the decisions, high cognitive loads. This is also empowered by our workplace culture, our accountability mechanisms and models that we have in place, and again, that lack of mechanisms to address discrimination. So when we are in high stress, high anxiety, where urgent and important decisions are made, these are ripe conditions for activating stereotypes. I'm hoping you can think of a few environments like this in the healthcare system. And so when you read that list of conditions that we just talked about, did emergency rooms come to mind for anyone, right? And in many areas of the healthcare system. The ER is one of the most common places for Indigenous people to be harmed by stereotyping. And we've actually learned from our research that harmful behaviors tend to occur more frequently in particular areas of the healthcare system, which we refer to as hotspots. These findings also align with the literature, and they're not surprising findings for us. So some of these hotspots are emergency room, the maternal or maternity and delivery care, pediatrics, mental health addictions, and home care and community care. So how do we start to address these issues? How do we start to address racism, discrimination, and stereotyping? And we find that when people hear about these stories, these examples that are shared, we want to point a finger. We want to find the person who has done this, the doctor that's provided the care, and fire them or deal with these people. But we know that firing, while it may make us feel good in the moment, it doesn't change the overall structure. It doesn't address the conditions and the environment that allowed these doctors or these care providers to treat our patients this way. So we know that racism happens at a structural level, as we went over, and that interventions need to focus on both, so the interpersonal level and, again, at the organizational or structural level. So going back to our iceberg model, we think about all the examples we've talked about, those experiences that have been shared. We know a strategy is needed to address the stereotyping and discrimination and anti-Indigenous racism at multiple levels. So the care delivery, leadership levels, everywhere and anywhere, really. This is just a snapshot of some of the examples of interventions that can be implemented at the variety of levels to address racism. So at the interpersonal level, we look at Indigenous cultural safety training, implicit association training, anti-racism trainings. At the organizational policy practice workplace level, recruitment and retention strategies, with emphasis from my lens on retention. Getting Indigenous people is important, getting Indigenous people into our systems is important. Keeping them safe while they're at work is more important, or equally important. And often there's more emphasis on recruitment in our organizations. And zero tolerance anti-racism policies. How many of our organizations have that right now? Accountability for discrimination. So are our HR processes, are our reporting mechanisms enough, is what we like to ask. And at the organizational level, this also looks at, do organizations have programs and services tailored to who works for them? So do the counselors, employee family assistance programs really support the needs of staff and volunteers and people working the system? At a systemic racism level, so the societal norms, public policy, media, public anti-racism campaigns have been found to be helpful. There's representation in our systems of Indigenous people, and a human rights lens is applied to our social policies. So what is cultural safety? When we talk about cultural safety, we're talking about making sure the kind of situations we've discussed don't happen. We're talking about making our system safer for Indigenous people and really safer for everyone. When we address inequity at the level where it's experienced the greatest, we improve the conditions for everyone. And so this is a working definition that we use at PHSA. Cultural safety is a process of making spaces, services, and organizations safer and more equitable for Indigenous people by considering colonial history and responding to structural racism and discrimination. So internally to PHSA, what are we doing about this? We know that these examples are coming in. We know that this type of practice is happening in care, or this type of behavior is happening in care. And so we've been working on an Indigenous cultural safety strategy to address racism across the organization and at those multiple levels. The strategy is organized into 6 action areas or elements, and the intention of this is really to understand how cultural safety can be advanced and expressed in an organizational context. So again, this looks at HR, people development, frontline service delivery, communications, community relations. It's intended to really demonstrate that everybody has a role in this, not just frontline care providers. We all have a position and a role and responsibility in addressing this. And also demonstrates that we need interventions both at the clinical level for the providers, and we also need them at the structural levels. I won't go into detail in terms of what's in any of those domains at this point, but what's important to note is that HR also happens in a department level. So there's a whole department called HR, but there are activities that we do within our departments that are HR related, that are service delivery related. Payroll, people often say to me, what possibly could payroll have to do with cultural safety? Indigenous people work in our systems. They have tax considerations. They're calling payroll to talk about this. It affects everybody, and how the payroll clerk or that payroll person responds to that Indigenous person affects their experience in working in our organizations. So we have a lot of work underway at our organization, and I know there's a lot of work going on across the system. And what I want to leave you with is some final thoughts on foundational strategies required for organizational change. What we've found is that typical change models or methodologies don't fully address the type of change we're talking about. There are helpful elements of those, but we need to be doing more to understand how we advance this type of change. So where we're at so far is, as priorities, is making health equity for Indigenous people a strategic priority. Mandates support this work. PHSA, or the Ministry of Health in BC context, has actually mandated cultural safety now. So this is a huge leverage point for our organizations. We know that we need to address racism at all levels within the organization, as we've chatted about. We need to create accountability mechanisms. This includes collecting data and building partnerships with our communities. Collecting data both on the inpatient side. How do we know who's accessing our systems? Do we know our patients are Indigenous? And as well on the employee side. Do we know who's working for us in our organizations? Identify, grow, and nurture leadership to support this work. That is critical to this. We know that in the way that our systems are designed and set up, we need everybody involved in this work. So I'd like to close just by sharing a teaching from one of our elders in our program, Jerry Ullman. He's been with our program for a very long time and really supports and guides our work. And in healthcare, we're often so focused on our successes and our feats. We don't pay attention to shortcomings. And paying attention to those shortcomings is actually the first step to addressing them. And as Jerry likes to say and remind us, we can't say goodbye to a problem until we've said hello. And with that, I'll leave you with a reflection. We'll have a Q&A as well, which Helen will help us facilitate. But I want you to think about, there's cue cards on your table, and think about what can you do to disrupt anti-Indigenous racism, discrimination, and stereotyping in your context, in your practice, in your organization, and what are some of those steps that you can contribute to. Thank you.
Much, Danielle. I really like your overview of the racism, the stereotypes, and biases that exist in our healthcare system from the individual level all the way to systemic, and give us a tool that's already existing. Is actually state-of-the-art. Danielle's training that we could all take in BC as well for people who are in Ontario and Manitoba as well. Can you tell us how do we access that training?
Yeah, sure. Actually, I think there might be one more slide. I may have skipped. Oh, no, it says right here. So sanyas.ca has information about our trainings. So we have some trainings customized to Winnipeg as context or Manitoba context, and others to Ontario. But our trainings are certainly applicable across Canada. So it's all there at sanyas.ca. And we also have a National Indigenous Cultural Safety Learning Series, which has webinars, had webinars monthly, and that's at that website below.
Thank you, Danielle. And how many in the room has already taken the training or in the process of completing it? Awesome. And for those of you who haven't registered for it yet, I would encourage you to spend some time in doing it, because it's a really powerful and thoughtful training in itself. Like after that, it's really helped me to check in with myself once in a while, like who I am and what biases and stereotypes do I hold, and how would that impact my work. Yeah. And so at this time, do we have any questions from the audience here? I'm trying to check my app. I don't see anything here. Okay, I'll bring you the mic. Hold on.
Diane, can you share some of the, oh, sorry, I'm Nancy. Hey, a social worker at St. Paul's Hospital. I'm interested in knowing some of the initiatives that you have seen some changes of attitudes, particularly with hospital staff.
Sure. So in our Sanyas program, particularly, we also have lots of examples where people have been able to disrupt practice and their own, practice particularly. We do often find that people report examples of other people perpetrating care issues, but certainly there are people who have spoken to how this has shifted their mindset, has given them tools to pause and ask and see patients differently. From an organizational context, we are looking at policy, implementing self-ID, organizational land acknowledgement guidelines and engagement guidelines. We're looking at facilities design. That's a huge one as well. Facility encompassing all of care environments. So what do our facilities look like, and how do we support that care? And part of that is actually having providers and patients to support a dialogue about that. What's different about our rooms now? What's different about how our environments that we're providing care in? So there's a wide scope of things going on, but I would certainly be able to chat with you after too. Is that helpful? Not really? Are you thinking more specific? Okay. Sure, just let me know.
Sorry. Hello, my name is Sarb, social worker from Fraser Health. I guess my question is, or experience also is the Aboriginal or Indigenous people's patients that I'm trying to help with. Sometimes there's so many issues, and we really try to support as much as I can, and our nephrologist, the whole healthcare team, and we have an Aboriginal health liaison in our health authority too, that sometimes I try to link patients up with too. And of course, you know, just understanding the historical context and the current context, and with all the mental health issues and systemic barriers and all of that. Sometimes I, as a clinician, am unsure about how much I'm able to assist with as well, because there's so many issues as well. And I do try to support as much as I can, and be aware of their own journey from wherever they are, and how we can link them up with services and really supporting them in their own healing. And I guess it's more just, I'm not sure at times, maybe it's a moral distress thing for me as well. Not sure of how much I can do, and because there's all these systemic barriers too, and what is the responsibility and accountability of the patient sometimes as well, along with our own systemic issues. So do you have any, say, comment on when we're kind of feeling stuck in those situations of, I feel helpless at times too, right?
Thank you. Do you want to take a shot? Your experiences? No. That's a good question, and I think when we start looking at how do we create a culturally safe system, it's informed by the patients. It's informed by Indigenous people. You know, we can't say our services are culturally safe. We need Indigenous people to be telling us that our services are safe. So part of that, and I recognize the sometimes the position that you're in. You're doing your best to address a variety of things. I think part of that conversation is asking the patient as well, you know, what do you need in this time? What can we do to support? I know there's limitations, and there's no checklist or right answer in this work. We don't know all the answers. We're trying things out kind of as we go too, because we don't have the structural supports in place. And so that is part of what we've been asking our clinicians and our frontline people to do as well, is start bringing that up. You know, what are the accountability mechanisms? Where are we supposed to be, or how are we supposed to be supporting patients and creating those networks of services? And often what we've been seeing is when people do bring that up, it's starting to create some change because those questions haven't been asked before. And at times when Indigenous health or Indigenous programs come in and ask those questions, the impact isn't the same as when the providers are asking. So I know it's not a neat, tidy answer, but I think what I want to leave is that you're doing something, and that's what we always ask, is do something. So yeah, I know it's not a neat, tidy answer, but yeah. We can share more about the details of the strategy if people are interested as well, and on the practice level. Yeah, sure.
Hi, my name's Christina. I'm a social worker at St. Paul's Hospital. My question is for Tiffany. So I'm wondering if you could share with us an example of a non-Indigenous person, a medical professional that you worked with, that you found was particularly a safe person for you, and kind of what made that person safe and what made that interaction really good for you?
If it's relative just to the kidney, I would say it would be Dr. Lowry. He was the first nephrologist that I ever spoke to, and I never saw him again. I saw him once when I first got to Prince George, and then when I moved back to Ottawa, he was there, and I went for a visit to see him, and he told me when I go back to see my kidney clinic and my doctors in Prince George, he said they're not like your doctors back home in Haida Gwaii. They don't have the time to look through your whole chart and see everything. He said every time you get a test done, you're going to have to go back to the doctor's office and question them about your test and find out what's happening, because they won't call you, they won't do anything. They have too many patients to go through. You're just a number on a chart to him, to any of the doctors. He was really personal. He took the time to go through everything in the chart, asked about the foods that I was eating at home, told me to reintroduce my cultural foods to myself, and it was really nice having him as the doctor.
Hi, I'm Alicia from CanSolve. I had a question for Tiffany. I just wanted to know what, as a patient, I know it's probably a lot of people who aren't in the medical field don't feel comfortable, and maybe you culturally as an Indigenous woman didn't feel that you could speak your voice, but I just wanted to know what prevented you from maybe following up with the doctors or pushing, because I know nowadays we try to tell people to be their own advocate, but maybe you, as you know, in your 20s or 30s, and being from Haida Gwaii, felt that, was it culturally you felt that they weren't going to listen to you, or is it just something that you never thought of doing to try to get people in the future to speak up and say, hey, you didn't tell me that I had kidney disease, and hey, you didn't tell me what my results were?
Since the age of 15, I worked at least 2 to 3 jobs. During 1 week, I would work 75 to 80 hours a week. I never took the time to take care of myself, so I never bothered asking the doctors anymore.
Can I add something? Yeah. I just want to add too that this is where when we pay attention to the colonial context, this shows up. When we look at the implications that our institutions have had on Indigenous people, there isn't a trust-based relationship. So we have to look at how does this responsibility shared on behalf of the provider. It isn't, from my lens, the Indigenous patient has been through a lot, as we've discussed in more simple terms, right? So what is our onus as providers to address this? The colonial context is really important. Our institutions have not treated Indigenous people well in any of the services, right? So having a voice in those systems is very difficult, especially when there isn't even mechanisms to have a voice. We have examples of where one patient tried to tried to find security services to complain, and he was escorted out, actually, of the hospital by those security services. So we say, tell us your story, we say share what's going on for you, but where are those mechanisms really that are safe in themselves? So, yeah.
Thank you. And there's a couple of questions online, but
Sherry, you could ask. Sure. I'm Sherry Kensel. I'm a nurse with Fraser Health, and I'm wondering if you have any tips on how do we support our peers that are Indigenous that we're working with into developing leadership skills and capabilities as we do. Are there resources or organizations that we can help connect them to?
So let me just make sure I understand. How do we support Indigenous people to take the leadership in some of this?
Yeah, Indigenous healthcare providers with us. So how do we support them in their leadership development as well? If we're saying we're not seeing enough
I see.
Aboriginal
Sorry.
people in positions of leadership in our healthcare, how do we help support that work?
Yeah, so some of the work that we're doing at PHSA as well, and there's many answers, of course, but some of the work that we're doing is around targeted recruitment strategies. And I want to take the organization a step farther. How are we supporting education opportunities to get Indigenous people into the door? We are looking at where do our postings go? I mean, I know from my context, and when I do my recruitment and hiring, it's a challenge to have our postings sent to networks that are Indigenous-based. And often some of the questions I get is, okay, this is an Indigenous-related posting, we'll send it to our Indigenous folks. every posting should go to Indigenous folks. Doesn't matter the context, right? So these are some of the questions that we get, and part of that as well is creating something we use is also racial caucuses in our work. And so what we do with that is we create safe spaces for racialized, our Indigenous and our non-Indigenous or our white settlers to have conversations, those tough conversations. And so part of that within the Indigenous context is supporting and mentoring, and that's also in alignment with how we do things as Indigenous people. We mentor, and so we have that set up as well. But it's also when we look at hiring qualifications, we have to take into consideration experience and look at what they bring differently in organizations. I'm not sure if that's helpful, but yeah.
Question online. There are unconscious bias tools. Do you recommend teams to use those?
Sorry, can you ask again?
There are, this person is saying there are unconscious bias tools out there. Do you recommend teams use any of those?
Yeah, so implicit association testing, I think, is one of those, or implicit bias association. We've actually been integrating that into some of our core curriculums as well. There are elements of that work certainly that help to surface where people can see their stereotypes and how they view other people. So certainly those things are important. Like SANIAS, we also frame SANIAS as a core foundational training. It's a start. It's not an answer. It's not the one L. Won't fix everything. It's a place to start in the journey. It's that core foundational piece, and similar to implicit bias association testing and similar things. So absolutely, under the umbrella of do something and do anything, yes. Yeah.
And the other questions, I think, is for both Tiffany and Danielle. What gives you hope for the future? Do you see change?
For the future, I want to see more people registered as a BC transplant. For Indigenous people, I will continue collecting the organ donation registration cards, and I will continue just trying to raise awareness without the First Nations communities. I want more people to get diagnosed, find out if they have it, see what they can do to slow down the progression, help with their diets, and hopefully things will start to get better in the future.
I would not be in this work if I did not think that the change was possible. You know, I think healthcare, as many people probably know, is a very fast-moving place to be and to work. And I think healthcare is uniquely positioned as well to really disrupt and move some of this change quickly. And this is one of the this is a system that I've seen move things fairly quickly. And I am hopeful. I want to see the change. And so, yeah.
Thank you, Tiffany.
Lots of work to be done, of course.
Yeah, for sure. Thank you, Tiffany and Danielle. And as I remember from Danielle's earlier presentation, each of us all have a responsibility and role in making this change. And so we would like to encourage all of you. There's some index card on your table, and we would like to encourage all of you to take a moment and think about what one thing, like after hearing Tiffany and Danielle, one thing that you would do to disrupt that racism, biases, and stereotype in our healthcare system. One thing in your role, you don't need any permission or anything. You just like think about one thing personally or professionally you would do to be part of that change. And we would encourage you to share your pledge with other people, because that's how evidence shows that you will be more likely to act on your change. And so hopefully the conversation will ripple out that way. Again, thank you so much for being here, and thank you again, Tiffany and Danielle, for this.
Thank you all.